It's always a pleasure to speak to the survivors and the survivors' families because, I mean, without you, we wouldn't be here. As far as from a disclosure perspective, I really don't have any. This is not a financial disclosure. I can promise you this is all done for free, but I am on the board. Uterine cancer, also called endometrial cancer. You also hear words like uterine sarcomas. They all fall under the malignancies of the uterus. They're the most common cancer that we take care of as GYN oncologists. But if you look at what they represent in the big cancer picture, it's only 6% of all cancers are endometrial. Let me just make sure I have my pointer here. Got it right there. Okay, so only 6% are uterine cancer. Now you might say, well, that's good. It is, but it's a problem. The problem is it's hard to study it when something is so rare. So when you look at, you compare it to something like breast cancer, where you have over 200,000 cases a year, well, that's a rich network to study and really make progress. So we make immense progresses in breast cancer. You know, we've made a lot of progress in uterine and endometrial cancer. The truth of the matter is that in general, we do pretty well. They only make up about 3% of the deaths. And when you look at this in another way, probably more tangent, if you have almost 50,000 uterine cancers in the United States in 2013, that's what we estimate through the statistics, we have about 8,000 deaths. So you can see that we cure the majority of patients with this cancer. And what I'm hoping to talk to you about is it's not just, uterine cancer is not just one entity. You know, just like breast cancer is not just one entity. There are different types of uterine cancer. And we try and make it very simple for us, and I mean us, not you, to sort of call them type 1 and type 2s, but it's not quite that simple, even though we try. But they're a cancer that obviously originates in the body of the uterus. It really doesn't include cervix cancer, and I tell patients that cervix cancer is kind of like when you talk about your face, and the nose is part of your face, but it's a separate part of your face. And so the cervix is a different part of the uterus. Sometimes for reporting statistics, they'll call it corpus cancer, and in there, that usually means the body of the uterus. That's what I'm talking about today. But some statistics throw in cervix cancer because they're connected. But I'm truly talking about corpus cancer, endometrial cancer, uterine cancer, 3 different words for the same thing. I'm going to show some pictures. I hope they're not too graphic, but just to show you what this thing looks like, because this is something that I always get asked, what does it look like? So first is just a little schematic. And when this is the body of the uterus, this is the fallopian tube coming off here. And you can see here is a cancer that's sort of a minimal cancer. You know, if this is one of the type 1 cancers, we would really expect to cure this cancer. Here's one that's more extensive, growing into the muscle of the uterus. So again, the uterus is the organ that has the baby, that delivers it and has to contract to squeeze it out. All the women in the room know exactly what I'm talking about. It's a painful contraction. So the cancer usually originates in the lining, and then it starts to penetrate the uterus. And this is one of the things that we look for to try and figure out who we need to offer more treatment for. How much has it penetrated? We also look for the size of the cancer. How big is it? And here's one where it has a lot of disease, and it's penetrating almost through the wall to the end. This is just a schematic. Now I'm going to show you real pictures, so bear with me. All right. This is a uterus that's been opened. So it's sort of filleted open. Think of it like a book. You open the book, so there are sort of 2 sides here. And in here, you see what we would call a polyp. A polyp, think of the word lollipop. It's kind of like the same thing. You have the candy on a stalk. This one has a polyp or a cancer on a stalk, and this one probably has some more disease in here as well. But that's one picture. Here's a more traditional picture. This one's opened, instead of opening the book this way, we're opening it this way, so from the top. So this would be the top of the uterus. This is the cervix, and this is the cervix, so you can see how they sort of would fold over. And the cancer part is this very granular part that you see here and here. This is the muscle of the uterus right around there. You can see it's invading pretty much in there, pretty deeply there. So this is what uterine or endometrial cancer looks like. Risk factors. I was very particular. I don't want you to think I'm ignorant. I was very particular here when I used the word white and black and African because there are differences there. And so I hope I don't offend anybody. I really don't mean any offense. But the reason I use those is because there are differences. Anyway, by far the most important risk factor is age. You can see that the median age is about 60 years, and it peaks around almost 80 years of age. Most of the cancers, 85%, are going to occur after 50 years of age. But you can see that still 5% of them occur under 40 years of age. And I was shocked, impressed, whatever you want to call it, last night at a meeting that we had, that 2 of our survivors were young women that developed this cancer. And you'll see they don't fit the prototype of what I would call a type 1 cancer. So another huge risk factor is obesity. And this is why this cancer is so prevalent in the United States, because the United States is a very heavy population. And you're going to hear words called meaningful use. This is stuff that we as physicians now have to abide by to make sure that we don't only take care of the patient, but we take care of the whole patient. So 2 things that you're going to hear more and more of are weight control and smoking cessation. Those are 2 controllable risk factors, not smoking for this cancer, but weight for this cancer. Because what happens is when you're heavy, you produce more estrogen, because there's an enzyme in the fat cells called aromatase. The breast oncologists play up on this and use aromatase inhibitors. And aromatase takes other hormones that you make and they convert it to a very weak estrogen. Now, although it's a weak estrogen, if you produce enough of it, it becomes strong and it stimulates the lining. So diabetes is also a risk factor, but it's the non-insulin diabetic. Why? Because those are the ones that tend to be more overweight. Those are more insulin resistant. And so you can see how this thing all plays into weight. Tamoxifen use. So you hear tamoxifen being used for a variety of cancers, the most common one being breast cancer. Tamoxifen is a weak estrogen, and you may wonder, well, why would they use a weak estrogen? Well, because it's better to bind the site with a weak estrogen than a strong estrogen at the breast cancer level. So that's how that sort of works. But the problem is that at the uterus level or at the endometrial level, the little weak estrogen actually does stimulate the lining to grow. And there are other generation, what we call SERMs, selective estrogen receptor modulators. That's what this drug falls into, that category, that don't stimulate the uterus as much. Other factors. Well, think of a woman's menstrual history. Those women that have a long menstrual history are probably at increased risk. So if you had early menarche, so if you had your period early, or late menopause, you had your period late, look at the total number of years of menstruation and ovulation. That means that you're not ovulating properly. And when you're not, you tend to have a lot more circulating estrogen, and you're not going through the normal cycle that occurs every month where estrogen would peak, then progesterone, which is sort of its counteracting drug, will bring it down, and then you start the cycle all over. When you're not ovulating, that estrogen doesn't peak, it just stays elevated, and it's that continuous stimulation. So you're going to see higher rates of this cancer in North America and Northern Europe, more so in North America because of the diet. The rates are lowest in Asia and Africa, again, probably because they don't have that much obesity in any one of those countries, and they probably don't use much hormone therapy either. This is where in the United States, the white people get this a lot more than the black people, a lot more than the others. But the problem that we have in this disease is there's a huge racial disparity. So if you compare African Americans now compared to non-Hispanic Caucasians, all right, there's double the mortality, lower 5-year survivals. Why? Why? Well, there's a lot of reasons why, but one, that the African American population has a higher frequency of what we would call the higher risk types that Dr. Barakat's going to talk about next. They tend to have less access to care, and if they have less access to high-end care, they might use surgery less than they should, and therefore surgery is by far still the best treatment for this. And perhaps less access to other therapies like chemotherapy and radiation. You know, they also come in with differences in medical comorbidities. They have a higher incidence of hypertension. SEER database, that is just nothing more than a database. It's looking at different counties across the country, and you can see that they come in with higher stage, higher grade. Grade is another word for how organized the cancer is. The more organized it is, the less aggressive it is. The less organized it is, the more aggressive. So higher grade means less organized. And more of the high-risk tumor types, as I mentioned. But it's interesting that even if you get them and you compare apples to apples, there are still differences. There are still differences in overall survival, suggesting that there's something else playing here. This is actually a very strong interest of mine, and something that I plead for our minority community to enroll in trials. I realize there's a huge distrust of the medical society there, But one of the reasons that we don't have that much information on the minority community, and I'm Cuban, so I throw myself in that group. I am Latino, Hispanic, and you put the Hispanics, the African Americans, put them all in that group. They don't enroll in trials. And if you don't enroll in trials, when we do research, the results are not going to extrapolate to you. And therefore, we need to increase that enrollment in order to do research on this population of patients so that we can tell them why, and we can figure out why there are differences, because there are differences. And I think it really crosses the social boundaries, but we always chalk it up for that. All right. So the uterus is a hormonally sensitive organ. It's relatively quiet before puberty. So before a young girl starts her periods, the uterus really is very, very small. The cervix is actually bigger than the uterus itself when that changes, once you start menstruating. And the reason that they start menstruating is because they reached a critical weight. And once they reach that critical weight, it's more weight-driven than age-driven, by the way. So if you look at your young daughters, why does an 11-year-old, she already has a period when a 13-year-old doesn't? Well, probably weight-related. So you look at our real athletes, the ones that are like this thin, you know, a lot of them have menstrual irregularities because they don't have enough fat to really support this process. So it's an organ that's incredibly sensitive to hormones. And one thing that you should all know, and you probably do already, bleeding after menopause is not normal. It's not. And the groups that get themselves into the most trouble here are the groups that I mentioned earlier, my minority population, my Latino population, the little grandmas from Italy that don't even speak any English. Oh, it's only a little blood. But a little blood you shouldn't have. That doesn't mean that if you have blood that it's cancer, but it means you should get it evaluated, because this is one of these cancers that the reason we have so many survivors and not as many deaths is because we tend to catch these patients early. And if we catch them early, we can really make an impact. So as I said, estrogen stimulates the lining to grow. The cells, what we call the endometrial cells, start to increase their mitotic activity in response to estrogen. What does that mean? That means they start to divide. They start to duplicate. And when they do so, they start to grow. Progesterone, that's another hormone that actually counteracts the effects of estrogen. And it actually offers stability to this growth and tends to curtail it. And it's why when you have a period, your estrogen levels peak. Then in the second part of your cycle, the progesterone starts to rise, and it gives it stability, and then both of them are taken away. This all happens in a month's time, and then that's when you have a period. And then the whole process starts over. So persistent exposure to estrogen, remember, tamoxifen use, unopposed hormone therapy if you still have a uterus, obesity, these are 3 examples where you have persistent, steady exposure to estrogen with no progesterone leads to this lining to grow, and if it continues to grow, it becomes malignant. So this is sort of what I was saying here, that as estrogen increases, it increases the activities of the cells. They start to make mistakes. So what happens is they grow, but if you start to increase the growth rate so much, there are more mistakes that are made. You know, we make mistakes in our body every single day. There are errors in DNA that occur, but we have a lot of different ways that we catch these errors, fix them, and go back to normal. But when the process is so revved up, we can't handle the errors, and then the errors become what we call these mutations. They come to hyperplasia, which is a precancerous event in this uterus, in this organ, and then become malignant. And as I said earlier, progesterone can reverse this process. So I mentioned earlier that obesity causes other hormones to be converted to estrogen. This is like a dirty trick because you go through menopause, you're dealing with the hot flushes perhaps. So how could you develop endometrial cancer? Well, because you're still producing other hormones at the ovarian level that are not at levels that you're used to, and they aren't even estrogen. But this enzyme called aromatase that lives in our fat cells, so that's why obese women have it more than a thin woman. They convert these hormones into estrogen, which then comes back and stimulates the uterus. Remember, non-insulin dependent diabetes. These are the diabetics that tend to be more overweight. They are more at risk. I told you about anovulation. Another word for that is insulin insensitivity. Again, going through the picture of an overweight woman who's not ovulating regularly, so she doesn't have the rise and fall of those estrogen levels. That estrogen level remains pretty high, and it can cause the cells to divide. I know I repeat myself, but somehow I've learned with my kids that if I don't repeat myself, they don't remember. All right, this is the crux of my talk here now. We tried to split them up into 2 broad types. Type 1, these are the cancers that are completely estrogen dependent. They're the most common one we deal with. You see, it's 85% of our cancers. They occur in younger women. They occur more commonly in the white population than the black population. There is a precursor. That's the hyperplasia that I told you about. So the cells are sensitive to estrogen. They grow. They go through hyperplasia. This is the time when we can truly make an impact because that's not a cancer, and we can treat that fairly readily. These tend to be the well-differentiated types. That means very organized. Remember, that's not the aggressive type. And endometrioid type, that's the name of the cell, is the most common. Let's compare this to type 2 now. These are by and large estrogen independent. So you'll see this in the skinny women that get this disease because they don't have that estrogen exposure. And so they're not as dependent as estrogen. They're much less common. This occurs much more so in an older population. Here, the racial differences are the same. Whether there's a precursor lesion or not, we think there is, but it's kind of a hard lesion to diagnose because you're usually diagnosing it after the fact, after you know they had a cancer. And when you look at the specimen, you can see, oh, they also have this. We have to figure out a way how we can diagnose this before the fact. People have looked at doing what are called endometrial pap smears. The problem is that test is still incredibly expensive and not ready for rollout to the public. But there might be a lesion. These tend to be poorly differentiated, less organized. Remember, less organized is less favorable prognosis. And the cell types that you see here are serous, not serious, but serous, clear cell, and any of the non-endometrioid types. These tend to fall into what we call the type 2 cancers. This is a little esoteric here, but just bear with me. When you look at the molecular differences, so in a laboratory, when you study these cancers, what are the differences? You'll see that this tumor suppressor gene called P53, so listen to the word, tumor suppressor gene. That's a good thing, right? It suppresses cancer. So you can see, you don't see very many mutations in that type. That's why these cancers, that's one of the reasons that we think that these cancers are good prognosis that we do pretty well with. Look at this one over here, the type 2s. The suppressor gene mutations are very common, i.e. it's not suppressing. It's kind of the simplistic way I remember it. P10 is another pathway we look at. These are much more common in the type 1 cancers, not as common in the type 2 cancers. You know, in 10, 20 years from now, maybe sooner, hopefully, you're going to see boutique medicine in cancer care, that not every patient is going to be taken care of the same way. That we're going to get a little bit of their cancer, and we're going to do molecular analysis, and we're going to figure out that each cancer is a little bit different, even though we lump them together, and that some cancers have molecular pathways that we can actually exploit. P10 pathway is one that we are currently looking at as exploitable. In other words, there are drugs that we can use that alter this pathway and may alter the aggressiveness of this cancer. But in the aggressive type, or the type 2, the P10 mutations are rare. On the other hand, HER2/neu, yet another gene, is a rare event on the good prognosis cancers, and it's a common event in the more aggressive cancers. There's actually a drug that's marketed already called Herceptin, and that's a drug that works on this pathway, the HER2/neu pathway. All right, now I'm going to get into some specific types. I think Dr. Barakat's going to cover this as well. Our talks are going to overlap. Again, repetition is good. It's good to hear it from somebody more handsome and taller than I, because you'll have a bigger presence here.
Very good judgment.
Endometrioid. You see? He's the president of our society, too. I'm trying to get some brownie points in here now. Endometrioid. This is the most common type. This is the type 1 cancer I was talking about. They tend to be not that aggressive. We cure the majority of patients with endometrioid type cancer. So these are the grade 1 and the grade 2s. Well differentiated, moderately differentiated. Remember, that's another word for organized. They frequently respond to hormonal therapy. So sometimes we'll get a young woman who doesn't have any kids, who has a grade 1 endometrial cancer, and she looks at other kids, is there any way that you can treat this and not take my uterus out? You know, there are some ways to do that. Is it considered the best treatment? No, but it's a treatment that we have to apply to that particular person and give her individualized care. And we've been able to reverse the effects of this cancer just with progesterone alone, have them get pregnant, achieve their children, and then take it out. They just don't respond as well to chemotherapy as some of the more aggressive types. Well, thank God we don't usually need to use chemotherapy on this group of patients because most of these patients are cured surgically. So hysterectomy plus or minus radiation. There's some other types that fall in here, and I'm only going to name them. I don't expect you to know them, but so you have them on your list, and it'll be on tape, and somebody can reference this, but filoglandular, mucinous. If you see a word called squamous differentiation, that's a good thing. That means that these cancers are changing into this squamous cell type that look like that, and that's actually a good prognosis. These tend to be incredibly organized cancers that are usually fairly straightforward to treat and cure. Ciliated type, and all of these that I mentioned tend to have an excellent prognosis. Okay, now you're going to shift to the type 2s, right? So poorly differentiated, even though it's endometrioid, poorly differentiated, poorly organized. These are more aggressive, so we put this in the type 2 category. These don't respond to hormones that readily because when you look at what we call hormone receptors, they don't have them at the same rate as the well-organized cancers do. So a lot of these patients frequently require additional treatment after hysterectomy. And whether it's chemo or radiation or both, they usually require more treatment. There's a group of cancers called undifferentiated. Well, undifferentiated, that means we don't know differentiation here. Well, that's a bad start right now when we don't know something. So you can understand why if we don't know something, these are probably going to be aggressive, and they are. They're not very common, thank God. Sometimes in this undifferentiated group, we'll see a cell type called glassy cell. That's just the name because of how it's, pathologists like to describe what they see. Sometimes it has nothing to do with the actual cancer, just describe it. They frequently use fruit in their descriptions because people can relate to things like that. But glassy cell is another subtype of this undifferentiated group that is aggressive. Serous, in my eyes, I think to call it serious is probably a good misnomer because these are the aggressive ones. These rarely respond to hormone therapy. They can respond to chemotherapy, but it's a shame that we have to even get to that point. When we're dealing with type 1s, we rarely have to use chemo. They metastasize early. So people will ask me, well, I have stage 1 disease. Why are you giving me all this treatment? Because you had a serous tumor. And a serous tumor is much more aggressive. And we know that patients with what look like stage 1A, in other words, it's a small tumor sitting on the lining, it hasn't even penetrated, can present with advanced disease down the road. And so these are tumors that we consider aggressive, and they frequently require adjuvant therapy. In fact, you almost have to talk me out of it. And you can. There are times that we can. You see it in the tip of a polyp, maybe that's one that doesn't need it. But by and large, most serous tumors we're going to treat with additional treatment. Clear cell. We're going to learn a lot more about clear cell cancers in the years to come because clear cell cancer is an entity in and of its own. You see clear cell cancers in the ovary, you see clear cell cancers in the kidney, and clear cell cancers in the uterus. And it's a predominance more in Asia. And so our Japanese cohorts have actually studied this more than we have because they have more patients with clear cell cancers. And they respond differently than some of the other cancers that I've talked about. They really don't respond to hormone therapy. And they're tough even to respond to chemotherapy, although chemotherapy does have activity here. And so we're looking at other pathways. Remember, I was mentioning that earlier, molecular analysis of these tumors. And there are things that these tumors create that we can exploit, and I think that's something that we're actively studying, and more to come there. So sarcomas, just briefly. A sarcoma, it's a little different word now than I've used. Sarcoma in any part of the body implies a malignancy. I didn't use the word cancer because it depends on who I'm talking to, but cancer, we all call that anything that's bad. Okay, but there's carcinomas. Those are cancers that arise in the cells that line things, what we call epithelial cells. Sarcomas arise in the muscle. When I showed you those pictures in the beginning, those were epithelial cells. Those were cells that arose in the lining and then invaded the muscle. Sarcomas, we believe, arise in the muscle and then invade from there. Now, the first sarcoma that I'm going to talk about, we might not be calling this a sarcoma very longer, and it's called a malignant mixed Müllerian tumor, also called an MMT, also called a triple MT, because there's 3 M's there. There's a lot of different ways we refer to this tumor. They're also called a carcinosarcoma. Now I really sound schizophrenic here, because is it a carcinoma or is it a sarcoma? Well, there's 2 components to this cancer. there is an epithelial component, so cells that look like the lining cells. That's the carcinoma component. And then there's a sarcoma component, cells that are not lining cells, that could be muscle cells. That's the sarcoma, so we call it a carcinosarcoma. There's a strong body of evidence in our literature that really is trying to refer to these more as epithelial and maybe not sarcomas, because the reality is they behave more like aggressive epithelials. When you look at how they metastasize, how they spread, it's the epithelial component that's usually the issue for us. These are aggressive, and this is another group of cancers that we treat aggressively, not just surgically, but chemotherapy, frequently radiation, all three. It's not uncommon to get all three. All right, leiomyosarcomas. This is a name for a cancer that arises in the muscle. Remember, a cancer that arises in the muscle is not a carcinoma, it's a sarcoma. Leiomyo is another word for smooth muscle. So smooth muscle, these are muscles we don't really control. So like the uterus is mostly smooth muscle. When it contracts, it does it on its own doing. You can't make your uterus contract. Your bicep, when you contract it, that's a striated muscle. These are the ones that I can say, okay, do this, but I can't make my uterus contract. So smooth muscle. There are some other places, I know, I don't have a uterus. There are some smooth muscles that we can, do have some control over, sphincters and things like that. But anyway, I'm just using this to make a point. So leiomyosarcomas are malignancies that arise in the smooth muscle of the uterus. They're aggressive, they're not that common, and these are hard because these don't respond very well to chemo or radiation. And so most people, if you get it surgically, you got it, and if you didn't, it's going to be hard to cure. These are not easy to cure. There's a whole group of other, just for inclusion, not really for discussion, rhabdomyosarcoma. These are more of the striated muscles that I was mentioning. So even though you don't have striated muscle in the uterus, these cells can actually change into that, and it looks like what we call striated muscle. Neuroendocrine, this is a subtype of cancers that has really nothing to do with your neurons, and it's interesting how I got the word neuroendocrine, but it's beyond the scope of this talk. But these are incredibly aggressive. You can see neuroendocrine tumors in all parts of the body. It gets a lot of press in the pancreas. You see it in the ovary. You can see it in the cervix. You can even see it in the vulva. And for today's talk, you can even see it in the uterus. These are frequently treated with all three things: surgery, chemo, and radiation. And then you got this other group of sarcomas that we call undifferentiated. Again, once again, if we don't know, if it's undifferentiated and we don't know how to differentiate it, it's usually a bad thing. These are rare and also quite aggressive. So how can I give prognostic factors to patients? How do I tell a patient, look, you should be okay? Grade and stage are by far the most important prognostic indicators, together though. So somebody with a stage 1, grade 1 being well organized, well differentiated, those patients should do well. I expect to cure almost all those patients. And when we have our tumor board every week and talk about our patients and figure out plans, we frequently say, you know, I can't remember a grade 1 patient that died. That's a good thing, because we do really well with these cancers, because most grade 1s are also stage 1. Now, stage 1, grade 3, that's a different person. That's a different patient. That grade 3 really dictates a lot more than the stage 1 does. Depth of invasion. So when we operate on patients and take the uterus out, I physically take the specimen to the lab. I do a timeout and I take the specimen to the lab and I open it up with the pathologist, and I'm asking him for 3 things: the grade, how deep is it growing into? Remember I showed you the schematic at the beginning where it was on the surface, then deeper into the muscle, and then all the way through. So depth of invasion, very important. And I'm also asking him, how big is it? 2 centimeters being our cutoff. We like to see it less than 2 centimeters, because less than 2 centimeters, if it's invading less than 50% of the muscle, and it's a grade 1 or a grade 2, you know, those patients really should do pretty well, and they don't need a lot of additional therapy. Lymphovascular space invasion. It's hard to tell at the time of surgery, but when you get your final report, remember, when a cancer spreads, there's a lot of different ways it can spread. It can spread directly, growing into something. It can get into the bloodstream and end up in other areas, or it can get into your lymph nodes. The way it gets into lymph nodes is through what we call these lymphovascular channels, these little highways that go from the uterus, these little carriers that take them all the way to the lymph nodes. And we can actually sometimes see that there's lymphovascular invasion, that the tumor started to invade these channels. Now, yes, patients with what we call LVSI, lymphovascular space involvement, have a higher risk of having nodal disease, has a little bit poorer prognosis than somebody who doesn't have it, but it doesn't necessarily mean that your lymph nodes are going to be positive. But it's certainly one of the things that we look for in our final pathology to discuss treatment. And then obviously the presence of lymph node metastasis or spread to the lymph nodes is very important, and that dictates a lot of prognosis as well. All right, I'm done. In summary, I've told you that not all uterine cancers are the same. We tried to simplify it into the type 1 and 2s, but as you can see, even within the 1s and the 2s, there are different subtypes. Most endometrial cancers, most of them, remember 85% of type 1, are not aggressive with incredibly high cure rates. That's the good news. Some are very aggressive and require aggressive treatment in response to them. That's the bad news. Almost all of these are going to present with abnormal bleeding. So why do we do so well with endometrial cancer? Is because most people know that if their bleeding patterns are abnormal, or if they haven't had a period in a long time and now they do, that shouldn't happen, and they get help. I tell you, if this disease were in men, we'd all come in with advanced disease, because at least women visit the doctor, they're interested, they're an informed consumer, where the male consumer is a completely different consumer in the doctor's office. I am guilty of it myself. I want to be in and out quickly. Don't tell me too much. Just tell me I'm okay and pat me on the door and get out. So most women present with abnormal bleeding, and that's why we catch this disease early. Remember, even a little spotting is important. Thank you.